I'm back. I wanted to just go ahead and I figured that I'd continue on with the reading just because I have a little bit of energy and I just kind of want to get through it. So I've read 1 through 6 and now I'm up to the 7th packet. This is notes 4A for the section 4A. After this, there is 4B and notes 5A. So there's essentially 3 more packets. This packet, packet 8, and then packet 9. Packet 8 seems to be a little bit thick, so I'm going to try and start that early tomorrow morning because I really would like to get these packets read so that I can go back and listen to them when I have a little time and then take time to review other things. So, Lactation Counselor Training Course Notes 4A. Breastfeeding shouldn't hurt. In a large randomized controlled trial, RTC of mothers with sore nipples, the participants with sore nipples in the group without commercial preparations had the same improvement as the mother in the groups with commercial preparation. But the group without the commercial preparations healed faster and had less need for follow-up visits. Finding: individualized assessment of the feedings, in addition to education and corrective interventions, was effective in reducing nipple pain and healing fissures in more than 90% of participants with sore nipples. Remember, pain was associated with every aspect of poor latch. Assess for proper latch on, good seal, baby's tongue, swallowing sounds, and reteach as needed. However, pre-feeding behaviors, state and cue, are more optimal latching process behaviors of the baby. Rooting, gaping, sealing, and sucking were related to less pain with sore nipples. Early stages of the infant's breast seeking and latching behaviors should be observed as well as the actual feeding. Nipples can also be infected. They heal best with antibiotics, systemic or topical. Lanolin users had 62% infection rate, non-lanolin users 18%. 2 practices. Hand on back of baby's head and shaping the breast appeared to interfere with the baby's interoral function by restricting the movement of the cranial cervical spine and nuchal alignment and were related to nipple trauma. Anatomical problems can also cause damage. Bottom lip turned in or tongue tie, lingual damage. A visual lingual frenulum is not the same as tongue tie. Researchers examined 200 healthy infants and found only 1 infant with no observable or palpable lingual frenulum. A lingual frenulum is a normal anatomic finding that is not correlated with breastfeeding difficulties. We suggest that the term lingual frenulum should be used for anatomic descriptions and that the term tongue tie be reserved for a lingual frenulum associated with breastfeeding difficulties in newborns. No correlation between Corylus type breastfeeding difficulties or cessation of breastfeeding. Out of more than 500 articles about tongue tie, only 8 are RCTs, 5 are related to short-term breastfeeding outcomes, and 3 are about the procedure itself. A systemic tongue tie research review concludes that a small body of evidence suggests that frenotomy may be associated with mother-reported improvements in breastfeeding and potentially in nipple pain, but with small short-term studies with inconsistent methodology, strength of the evidence is low to insufficient. So basically, all the snipping of the tongue ties and the lip ties is inconclusive, and we probably are doing it too much. I actually read a recent article that suggested that we are doing this procedure too much and that's not actually leading to better outcomes. The outcomes seem to be more anecdotal than data-driven. The role of the lactation care provider: read tongue or lip tie. Complete upfeeding assessment and suggest ways to optimize latch. Refer onward for diagnosis unless the LCP has diagnostic credentials. Provide the ongoing support. Pacifier and feeding bottles in the hospital were both associated with sore nipples at discharge. Mothers with sore nipples were significantly less likely to leave the hospital exclusively breastfeeding. What about creams? 1. Continued questions of effectiveness. 2. Fears of ingestion by baby. Other reasons for nipple soreness: oversupply, baby trying to hold back flow by clamping down on the nipple. With oversupply, hyperlactation, you also usually see rapid weight gain, unsettled baby, especially after feedings, recurrent plugged ducts and mastitis, painful feedings, voluminous, high volume of stools, often green and shiny. From the LCP's perspective, green shiny tools indicates need for feeding evaluation. Is there a deep latch with nipple stretching? If the nipple is not stretched deeply into the mouth, less oxytocin flows and therefore less fat is in the mix. With less fat, the milk is digested more quickly, perhaps leading to not enough time for lactase to digest the lactose. With improved latch, more fat flows and slows down the digestion, allowing time for lactose to be digested. Is there either overactive letdown and or overproduction of milk? Is there a lot of milk at once? The production of lactase may not keep up with the amount of lactose. Decrease additional stimulation or milk removal if possible. Consider block feeding. Nurse on one side only per feeding. Try Australian posture. Watch for mastitis. Consider donating to a milk bank. If lactation management solutions are ineffective, consultation with HCP, with healthcare provider for medical diagnosis. Tremoloni and Spencer. Candida albicans, yeast, or thrush. Is thought to cause pain for mother and or baby, may be visible or not. Mother will usually have itchy, flaky skin and shiny skin. Treatment of Candida includes simultaneous pharmacologic treatment, in recurrent cases possibly other family members as well. Nystatin ointment is typically the first round. Fluconazole, diflucan, or oral capsules may be used also cleaning or replacing yeast vectors, toys, pacifiers, pump parts, etc. Pacifiers are contaminated with Candida biofilm. If treatment doesn't work, it may not be yeast. Researchers are now asking the question, is breastfeeding yeast a medical condition without scientific evidence? Even when there were symptoms of severe nipple and breast pain, Candida was not found inside the ducts or milk. Antihistamines were found to relieve symptoms when there was persistent pain through thought to be yeast. Raynaud's phenomenon of the nipple is often treated inappropriately for organisms such as Candida albicans. It is not the same as blanching due to poor attachment during feeding. Involves vasospasm of the nipple recognized by a tricolor sign, white, blue, raspberry, or the bicolor sign, white, raspberry. Pain is extreme and spasmodic, not continuous. Treatment of Raynaud's includes preventing or decreasing cold exposure, avoiding vasoconstrictive drugs, including some hypertensive drugs, plus caffeine or nicotine. Pharmacologic methods, especially nifedipine procardia, a calcium channel blocker. What if, despite an optimal latch, there is persistent nipple pain during feeding, suck and pause, with poor milk transfer? In rare cases, babies have a strong sucking vacuum as measured by a pressure transducer or nipple shield. Clogs or plugs or cakes. Palpable lumps of milk within the lumen or duct system, usually not visible. For clogs, 1. Find out cause, especially in recurring, i.e. bra. 2. Massage, warmth, double nursing may help. Point chin toward clog. See a healthcare provider if systemic symptoms appear or if clog does not move in 24 to 48 hours. Clogs may appear at nipple tip as a bleb, small white spots on the face of the nipple that look like milk-filled blisters. One duct opening is usually covered. Women describe stabbing pinpoint pain. Blebs may exit when treated as clogs. Sometimes blebs may need to be lanced by the healthcare provider. Common mastitis, breast inflammation, can be non-infective or infective. Common mastitis, breast inflammation. Factors commonly associated with mastitis: blocked ducts, e.g. from engorgement, hurried feedings, use of nipple shield. Attachment difficulties, tight bra, use of a breast shell, nipple pain, anemia in the mother, tongue tie in the baby. Systemic, fever, ill feeling, redness, pain, one inflamed breast. If infective, most probably staph. The problem is generally not in the milk, but in the tissues of the breast. Medical intervention is needed. NSAIDs are the usual first step. Antibiotics for mastitis. Cochrane. Little evidence of effectiveness of antibiotics for one breast common mastitis. Keep milk flowing and breast soft and comfortable to avoid abscess development. Nursing with common mastitis is not controversial. If treatments are ineffective, consider anemia, ductal, or inflammatory breast cancer. Uncommon and emergent mastitis. The tissues of both breasts are inflamed. Strep is the probable organism, a potentially fatal whole-body inflammation, sepsis. This is not a problem with the milk. Methicillin-resistant Staphylococcus aureus, MRSA, can look like mastitis when it's on the breast. It is a newly recognized issue, can also cause lesions and abscess. Abscess. Pus is not milk. As many as 60% may be positive for MRSA. Nursing on the other breast is possible. No clear clinical consensus about nursing on breast with abscess before or after drainage. Surgery may cut through nerves and ducts. Instead, drainage of breast abscess with ultrasound-guided technique has been shown to be efficient and safe and should be the first choice. Any suspicious area or appearance of the breast nipple areola should be referred at once to a qualified provider. It could be MRSA or herpes, deadly for babies, so no breastfeeding or breast milk. Careful assessment is needed when the baby slips off the breast, tires easily, repeatedly latches, and sucks only a few times before letting go of the breast. Remember, any recurrent feeding problem needs evaluation or referral. Goldsmith sign. Baby won't latch onto one breast. Persistent newborn refusal to nurse on one breast is of concern, but one breast refusal may also happen suddenly with older babies. Rule out common problems such as ear infection, teething, birth trauma. Breast cancer is also a possibility that must be medically monitored. CA must be, CA may be diagnosed as late as 5 years after Goldsmith sign. Recognition of Goldsmith sign is vital and will enable early diagnosis and improve prognosis of breast cancer. Neonatal hypoglycemia, low blood sugar. Healthy term newborns who are breastfed on demand and are asymptomatic do not need blood glucose routinely checked. AAP guidance, ABM clinical protocol number 1. AAP guidance current evidence does not support a specific concentration of glucose that separates normal from abnormal. However, a reasonable, although arbitrary, cutoff for treating symptomatic infants is 40 milligrams. NH occurs most commonly in infants who are SGA, LGA, born to mothers who have diabetes, and late preterm infants. Greatest attention should be paid to neurologic signs in these babies. Symptoms include jitteriness, cyanosis, blue coloring, apnea, stop breathing, hypothermia, low body temperature, poor body tone, poor feeding, lethargy, seizures. Jaundice is a yellow coloration of the skin and the sclera, whites of the eyes. The yellow coloration is caused by unconjugated bilirubin. Advancing jaundice requires clinical evaluation. Types of jaundice. Pathologic occurs before 24 hours of age, usually due to sepsis, blood incompatibility. Early onset peaks between 72 to 96 hours, often called physiological or starvation or lack of breastfeeding jaundice, frequently related to underfeeding. Treatment for jaundice should not prevent mothers from breastfeeding, but jaundice babies are sleepy, lethargic, and have difficulty sustaining the feeding. Late onset, often called breast milk jaundice, may actually be related to metabolic or other issues with the infant, e.g. G6PD, Gilbert syndrome, UTI. Benign, prolonged unconjugated bilirubin associated with breastfeeding. Presents in second week and persists for 12 weeks. Current research does not support the discontinuation of breastfeeding. Instead, a thoughtful investigation and monitor until total falls below the recommended level for phototherapy. Why are we concerned about jaundice? kernicterus. Unconjugated bilirubin is fat-soluble and crosses the blood-brain barrier easily. Therefore, if the amount of UCB is too high, it has the potential to cause damage to the brain, spinal cord, and nerve cells. Warning signs include jaundice advancing from the upper body to the lower body, fussiness, lethargy, feeding difficulties, fewer than 4 wet or dirty diapers in 24 hours. Any jaundiced baby has the potential for kernicterus and should be closely monitored. Skin-to-skin influences the state organization and motor system modulation of the newborn and can help with difficulty latching and sustaining a feed if it's not just for right after birth. Kangaroo mother care, a special kind of skin-to-skin holding for premature and fragile babies that has been shown to decrease mortality by 36%, as well as sepsis, hypoglycemia, hypothermia, and hospital admission. The adult stays in an upright position, may last for hours, even 24. Preemies who have kangaroo mother care or skin-to-skin have better long-term physiologic organization and cognitive control, have improved cerebral blood flow, have improved weight gain, may have nostrils decolonized that have been colonized by RSE organisms, have sleep patterns that are more mature, are warmer and more physiologically stable, may have better breastfeeding outcomes. VLBWs under 1500 GM at birth have longer breastfeeding duration if they have been cared for skin-to-skin. A small study of skin-to-skin with preterm twins found that each breast increases temperature separately for the closest baby. Even VLBW babies were significantly warmer in their mother's arms. Babies burn fewer calories while being held than in the incubator. And that is the end of the notes for 4A. Thanks for listening.